dear colleagues. First of all, I want to thank to Professor Assad for organizing the course and including me here. I will talk about IOL fixation using Gore-Tex sutures, which can be perceived as more or less a classic way of handling such a situation. The only thing that is a bit different is that the type of sutures that I'm using. This is my disclosure relevant to the presentation, and obviously the Gore-Tex sutures, which are intended for cardiosurgery, are off-label used here. Why we use Gore-Tex sutures? Because they are tissue forgiving, meaning that they don't erode the sclera or the tissues through which they pass, and also the knots are not leaking, which is important. So the Gore-Tex fixation in my hands is something really robust, and would be my choice, especially for younger patients where we have long life expectancy. So on the picture you can see the CV8 Gore-Tex suture that you need to source if you want to perform such type of fixation, and I strongly recommend you anterior segment micro instruments, micro forceps and micro scissors. Why they need to be anterior segment? Because they are curved, and when they are curved you have a better access and movement in anterior chamber. It can be done with classic vitreoretinal instrument, which is absolutely straight, meaning that from the temporal part you might be okay, but from the nasal side you will be constricted in terms of movement because there is no bending of the instrument. You can use whatever you want manufacturer as long as the instruments are working in your hands. The gauge is important. The gauge should be 23 or 25, and I prefer to make the incisions with 23 gauge NVR blade, and to enter with 25 gauge instruments. That way I am sure that I'm not detaching the ciliary body, and I cannot create a subtle psychodialysis, which is really important in this type of fixation. Regarding the lenses, you have two options. One option is to be prepared, because you know that you're gonna operate a phakic eye, and every type of design who has eyelets which are symmetrical, you can use them. Here I'm shown more of the famous or well-known lenses that you might find. The other scenarios is that you might have a lens inside which you can salvage also. So always examine what type of lens is inside of the eye in order to prepare your strategy, what you're gonna do. So I'm using for that technique horizontal scleral pockets. My main or first incision is roughly in between 3.2, 3.5 millimeters from the limbus, and then I create a pocket which aims to 2.5 millimeters from the limbus. With 23 gauge NVR blade, I enter parallel to the iris, facing a bit down, in order to be able to pass my Gore-Tex sutures. This is a traumatic case, which is also with retinal detachment, but this is another story. And I needed to first suture a IOL and later on to perform the vitreoretinal procedure. Why I need to have a lens there? Because if I use silicone tamponade, I need to have a barrier. So these are my second incisions here. Vitrectomy, very hot topic. Do you need to do it? How much do you need to do it? Do you need to clean the base or not? Since I'm a vitreoretinal surgeon, I believe that as good as vitrectomy can be, it's better for the eye. But at least we need to clean the vitreous, which is in contact with the iris and enters the anterior chamber. And also we need to clean the area of Berger. We need to clean the anterior base in order to not engage vitreous strands with our sutures or instruments, which we will manipulate in that space. Now here I'm implanting a 4 eyelet IOL, and I guarded it with a spatula in order to land it over the iris. Then you can position your lens with a dialer, Sinski, push-pull, whatever the instrument that you prefer to use in that situation. You need to align the lens in a way to be convenient to be approached with instruments. The difference which is in my technique compared to the classic technique for Gore-Tex suture is that I pass the sutures inside the eye. That way I avoid opening the cornea to 5-6 millimeters to introduce the lens with pre-passed sutures through the eyelids. Now, with the handshake technique, that is why it is important to have a proper instrument. You can gently pass the Gore-Tex suture through one eyelid of the lens, then through the other. So it's quite easy actually, but it should be, of course, rehearsed. And in that way, I don't do any different incisions than 2.2 as a regular cataract incision, and I have 2 side port incisions. So now you can see the second suture goes and forms a loop. Now you can push the lens behind the iris here. The case is really delicate because you see how thin is the iris connection due to the trauma on the left side, and when you are careful enough, you can manage to implant and suture this lens without inducing additional damage to this iris. Remember that this is a vitreoretinal case, so I need a good diaphragm between posterior segment and anterior chamber. Again, on the other side, handshake technique. Again, I will stress that the instruments are absolutely mandatory here, otherwise it will be a bit of a struggle with straight instruments. Here is the second part of the suture. What you need to have also is really sharp scissors, because the Gore-Tex is quite slippery. This is a Teflon based material, so in order to cut it you need to have a sharp scissors, which is important. During the tying, the first loop is most important, 3 or 4 times. Then you need to pass at least 1, 2 or 3 single knots in order to lock the suture. Of course, you can titrate the position of the lens and how to fixate it in the eye before locking the knots. What I like with the horizontal scleral pockets is that even the Gore-Tex is under sclera, so it's not visible and it cannot erode the conjunctiva at all. So another case where the different type of lens is here, but it's actually a lens which was luxated inside the eye, meaning that you can salvage what you have in the eye of the patient. That way you will not explant it by cutting it in the anterior chamber and then implanting additional lens. This is also something that is quite useful and forgiving for the cornea. Here, as I said, you need to have symmetrical openings of the lens in order to be well positioned. Otherwise, it might tilt or not to be well aligned in the eye. Of course, vitrectomy, it's mandatory here. And again, these horizontal scleral pockets will be used in order to conceal the knot and the Gore-Tex suture. Later on, under a slit lamp examination after 2 to 3 weeks, if you don't know that the lens is sutured and you don't dilate the pupil, you will not recognize that something like this has happened with the eye. Again, handshake technique. One of the benefits here is that you have 2 scleral enterings which might not hit the horizontal and long ciliary arteries, because normally they are on 3 and 9 o'clock. So here you are a bit more safer compared to a single scleral opening for different type of scleral fixation. This is also important. Now you can push the lens, of course, behind the iris. What I like is that I have almost complete control over the fixation of the lens. I can titrate where the lens will be, and the first and most important thing is that you need to have absolutely opposite positions of your incisions in order to have well-aligned lens. So this is how the eye looks later. And my take-home message would be use proper planning and instrumentation. And here you can see the Gore-Tex CV8 suture and suitable IOL, 15 to 30 degrees knife and crescent knife, 23 gauge NVR blade, and dedicated anterior segment micro instrument. You need also absorbable 8-0 sutures to close the conjunctiva. Thank you.